We're here on behalf of the Paper 4 team. I'm the senior author, co-lead author. Catherine Hay is somewhere in this audience, raising her hand, yay. We're here to present for the Paper 4 team, inclusive of Dr. Sigurthi from Population Council. So you've seen a little bit about how gender inequalities are shaped by gender norms, how these gender norms and inequalities affect health, and how policies and community programming can make change, gender transformative programming. But what does it mean for the healthcare sector? We're here, many of us are from the healthcare sector. We are invested in trying to understand how to make health systems work better. To that end, we had two questions in this paper. How do restrictive gender norms and gender inequalities manifest in the health system? And how can we disrupt health systems in ways that address, reduce, or prevent these inequalities and the underlying restrictive gender norms that maintain them? I'm going to talk a little bit about what we found for question one, and then I'll hand off to Dr. Sigurthi for question two. So we approached these questions using feminist theory, and by feminist theory, the approach we used was multidisciplinary, multinational, and multi-country. And we included secondary data analysis, but all the primary data analysis was led by in-country authors. We worked very hard to include people from across 4 separate continents. What we found was, first, in examining the healthcare systems models of systems, the most commonly used models don't actually specifically comment on gender inequalities. They may focus on addressing social disparities or disparities, social determinants of health, but not inequalities as relates to gender. They can be operationalized that way, but they don't explicitly state them. The second thing we found was, when you actually look at how the health system is responding to gender inequalities in health, you see a couple of things. First of all, they're reinforcing them. Much of our services are built around maternal and child health. What if you're an older woman? As a woman no longer of childbearing age, I can say that the health system doesn't respond to me in many cases. What about men? And what about sexual and gender minorities? When we looked at, for the gender inequalities that persist, things like son preference, differential access of care in India, for example, for boys versus girl children, we see that the response is largely, these are social issues, it is not the responsibility of the healthcare sector. So in essence, we see either a reinforcement of these gender norms or actually a complete disengagement and feeling a sense of responsibility to address these gender inequalities in health. And finally, we wanted to understand how this played out in the healthcare workforce specifically and the way care delivery then transpired from there. And I'll show you in this slide, what we can see in the blue is how this affects the patients and communities, and in the purple, how it affects the workers. So in the blue, we can see that there's differential value of patients. So certainly we prioritize maternal and child health, but also we increase the value of patients that are from our more valued members of society. We've been talking about intersectionality. Part of intersectionality is how do we take care of all people? Universal health care coverage is supposed to be meeting the needs of all, but those most socially marginalized tend to be least valued. There are differential barriers to care that are not addressed for these marginalized populations or for populations not prioritized to receive care. There is differential inclusion in the healthcare decision-making on the part of the healthcare sector. This is a patient, I am the knowledge bearer, you don't understand, I will tell you what to do. And consequently, and not surprisingly, you see differential care seeking, diagnosis, and treatment. If I am being neglected by the health system, if I am being disrespected by the health system, and if I am being abused by the health system, why would I go to the health system for care? So what does this look like inside the system itself? Well, first of all, we found that we have very, very differential, a very gendered workforce, whether that be that 1 in 3 of our health ministers is female, whether that be that globally only 1 in 3 physicians are female, or if we see that 90%, in many countries, 90% or greater of our nursing workforce is female, and by law, by legislation, our community health workers in some nations are exclusively female. And it creates something we call the cure care paradigm. Who's at the top? Who's making the decisions about healthcare? Who is respected? Who is valued? Who has the scientific understanding to cure? What you saw in the video seen earlier, it's men. And who are our care providers? Who are the nurturers, the ones that will be there for us? The ones who do this altruistically because they are committed to the local community. These are our community health workers, our nurses, and they tend to be our female providers. There's an expectation of altruistic versus financial motivation. There is greater respect at the top and least respect at the bottom. And when we see this lower or differential representation, we see differential treatment, a kick-down effect. The least valued members are the lowest, and at the lowest, they are not only the least valued, they are oftentimes the ones that then perpetrate abuse and or poor treatment for the people that need it most.
The three solutions that we have chosen to include are one at the policy level, the norms that reflect it at the policy level, and the norms that reflect at the health workforce level, and then the norms that reflect at the community level, where most of the primary care happens. So at the policy level, the question that we have asked is whether nations which have higher female physicians per capita are the ones which have the better access to health and the resources. And the findings from that case study indicate that the nations with higher female physicians per capita are the ones which have shown to have much greater availability of the workforce, recognition, and the representation and compensation and respect. The second case study that we have included refers to the health workforce because, as Anita stated, most of the health physicians are men, and on the contrary, at the primary care there are more women. Why would men would like to be in the at the primary care level? Because there is less respect, less support, less pay, and more abuse. And the second question that we have chosen to ask is that whether the support and respect that at the healthcare workforce level will it affect the greater performance and health impact. So what the findings indicate that the family support and community respect actually reflects the greater health worker productivity, and at the same time the family support, mainly in terms of the sharing of the domestic responsibilities, are reflective of greater utilization of the healthcare services. And the third and the most important, the case study, which was based on evidence trial from India, which indicates that the self-help groups that work with focus on health, as compared to the women from the control groups, were much more likely to receive the good quality of care, because the demand for quality of care is important, and that can happen and will happen with only the proper community accountability mechanisms. And the paper, while you can actually read the details of these case studies in paper, the paper concludes to say that the health system, there is disruptions can happen in health system from both within and through social and economic policies and through community accountability mechanisms. So individuals who are interested to change the health system must ally and align with social movements, activism, and the community mobilization, because that for change and accountability at the health system level. Thank you, and I invite Nandini